Okay, good morning. Thank you for coming today. First, I'm going to talk about a trial for allogeneic transplantation patients with persisting or relapsed disease after transplant. You can see it's entitled Allo T cells expressing an anti-CD19 chimeric antigen receptor cause remissions of B-cell malignancies that progress after allogeneic hematopoietic stem cell transplantation without causing graft versus host disease. First, some background. Relapse of malignancy is a leading cause of death in patients undergoing allogeneic stem cell transplantation. B-cell malignancies persisting despite allogeneic stem cell transplantation are often treated with unmanipulated donor lymphocyte infusions. These infusions of unmanipulated donor lymphocytes have very inconsistent efficacy and are associated with significant morbidity and mortality from graft versus host disease. We aim to improve the treatment of B-cell malignancies that progress after allogeneic transplantation by infusing allogeneic T cells that were genetically modified to express an anti-CD19 chimeric antigen receptor. So, in short, we're trying to genetically enhance the donor's own lymphocytes to make the infusion of lymphocytes more effective. First of all, what is a chimeric antigen receptor? It is a fusion protein that contains an antigen recognition domain, usually derived from a monoclonal antibody. It's fused to co-stimulatory domains and T cell activation molecules. The CAR gene is put into the T cells via a vector, usually a viral vector. In the case of the research I'll present today, it is a gamma retroviral vector. The CAR is then expressed on the surface of T cells, and the T cells can recognize the targeted antigen on the tumor cells. Patients with any B-cell malignancy were eligible for this protocol. Patients had to have at least one standard DLI, except for one exception. We would accept acute lymphoid leukemia patients who did not have a prior DLI, because prior DLIs are very ineffective for acute lymphoblastic leukemia. Patients must have had minimal or no graft versus host disease and not be receiving any systemic immunosuppressive drugs at the time of protocol enrollment. One very important point about this study, in very distinct contrast to almost all other CAR studies, is that we did not give the patients any chemotherapy. So the results you see will be due to the cells that we infused. There were no other treatments administered at all. So it's a very non-confounded and clean experiment. The CAR transduced T cells were derived from the original transplant donor. So as I mentioned, these are patients that had allotransplants, either matched unrelated or sibling transplants. So we went back to the original donor and asked them for another donation of lymphocytes to produce these cells. The production of the allogeneic anti-CD19 CAR T cells took only 8 days for each patient. This was a phase 1 trial, which was a dose escalation, and the highest dose level reached was 10 to the 7 total cells per kilogram. We treated 20 total patients. We treated 5 patients with acute lymphoid leukemia. 4 of 5 obtained minimal residual disease negative complete remission. That means there was no leukemia detectable by the most sensitive methods, including PCR in one case and multicolor flow cytometry for all the patients that obtained complete remissions. One of these complete remission patients has an ongoing complete remission at 18 months. 2 later relapsed, and 1 went on to a second allogeneic transplant and continues in complete remission. We treated 5 patients with chronic lymphocytic leukemia. 1 obtained a complete remission, 1 a partial remission, 1 stable disease, 2 progressive diseases. Both the complete remission and partial remission patients have ongoing responses at 36 months and 18 months respectively. The partial remission patient has a very small amount of one lymph node that's less than 2 centimeters in her pelvis, which is possibly scar tissue, but officially partial remission by the international staging criteria. We treated 5 patients with mantle cell lymphoma and obtained 1 complete remission and 1 partial remission. And with diffuse large B-cell lymphoma, again, 5 patients treated, 3 stable diseases, 1 CR, 1 progression. The stable disease is ongoing. The patient with complete remission is actually still in complete remission, but she's not evaluable anymore because she received other therapies for her chronic graft versus host disease, which could confound results. This is a slide of the patient with diffuse large B-cell lymphoma who obtained a complete remission on the study. This patient, you can see the large lymphoma masses in her head, one in the back of her head, one in her eye socket. 15 days after infusion, we repeated an MRI of her head, and it shows that the tumor masses were completely gone. Amazingly, the tumor masses completely disappeared within 5 days of the CAR T-cell infusion. And this patient, as I mentioned, she had some chronic graft-versus-host disease at the time before we gave the CAR T-cells. This chronic graft-versus-host disease continued to steadily worsen before and after the CAR T-cells, and she went on to get other therapies for her graft-versus-host disease, but continues in complete remission now about 13 months after the infusion. In summary, we treated many patients, 20 patients with very advanced malignancies. Please keep in mind that these patients who failed all standard therapies went on to allogeneic transplant, which is considered the last chance therapy for these patients, and continued to have progressive malignancy after that. So it's a very, very high-risk patient population. I didn't show today some of the actual slides of the ALL patients, but we had very good responses with ALL, as I mentioned. But many of these ALL patients with high tumor burdens did have severe cytokine release syndrome with fever, tachycardia, and hypotension, among other toxicities that I'll discuss later today, actually at 12:30 today, in much more detail. Neurological toxicity was rare and mild. Only one patient had mild aphasia. This is in contrast to some other CAR studies where neurological toxicity is much more prominent. When chemotherapy is not given, a higher dose of CAR T-cells can be given with acceptable levels of toxicity. No acute graft-versus-host disease occurred after the allogeneic CAR T-cell infusions. Only one patient had continued worsening of pre-existing chronic graft-versus-host disease, which I already mentioned. One patient developed very mild chronic eye graft-versus-host disease more than a year after CAR T-cell infusion, which was probably not related to the CAR T-cells because she had no detectable CAR T-cells in her blood at that time. Thanks. Yeah, let me just go ahead. All right. So I'm going to present another abstract now. This one was a completely different CAR, a different disease. It's remissions of multiple myeloma during a first-in-humans clinical trial of T-cells expressing an anti-B-cell maturation antigen, chimeric antigen receptor. We abbreviate B-cell maturation antigen BCMA. And it's a somewhat confusing name. Although its name is B-cell maturation antigen, it's actually mainly expressed on plasma cells. So B-cell maturation antigen, a target for CAR T-cell therapies of multiple myeloma. Multiple myeloma is an almost always incurable malignancy of plasma cells. Novel therapies are urgently needed. BCMA is also known as CD269. It's a member of the TNF superfamily. It is uniformly expressed on 60 to 70% of cases of multiple myeloma. We did extensive preclinical work on BCMA, and we were the first to ever publish an anti-BCMA CAR, and this work was published in Clinical Cancer Research in 2013. So if anyone's more interested in the background, preclinical stuff is there. By quantitative PCR, we found BCMA only in bone marrow lymphoid organs and organs known to have plasma cells in their lamina propria. By immunohistochemistry, BCMA is only expressed by plasma cells and a small fraction of B cells. This specific expression is very important because we don't want the BCMA to be expressed on any essential normal organs that might be harmed by the T cells that we infuse. But luckily, BCMA is strictly expressed by plasma cells and a few B cells. The CAR that we used in this study we call CAR BCMA. It was synthesized and ligated into the MSGV gamma retroviral backbone. Replication incompetent gamma retroviruses were produced and used in T-cell transductions. The T-cells were produced in a culture process that took 9 days. T-cells expressing this CAR recognize BCMA with great specificity. You can see the diagram of the CAR there. This CAR also had a CD28 costimulatory domain and a CD3 zeta activation domain. This is an overall summary of the patients we've treated so far. 12 total patients with a dose escalation study. You can see that the early dose was very low, 0.3 times 10 to the 6 per kilogram. We then increased the dose progressively, and when we reached higher doses of 3 times 10 to the 6 or 9 times 10 to the 6 per kilogram, we saw much better responses. Patient 10 had the best response on the study, but also significant toxicity. He had cytokine release syndrome, including fever, tachycardia, hypotension, elevated liver enzymes, and elevated creatinine kinase, all resolved in 2 weeks or less. The patient's absolute neutrophil count was less than 500 at the time of CAR T-cell infusion and remained low for 40 days after infusion before recovering. It's now recovered completely. The patient was platelet transfusion dependent for 9 weeks after infusion. So this patient was really the patient who had the most toxicity on the study and also the one who had the best response. He did have significant toxicity, but is now recovered. Patient 10 also, as I mentioned, had by far the best response. He obtained a stringent complete remission, which is a very strict definition of complete remission used in multiple myeloma. His serum and urine immunofixation test became completely negative. His bone marrow flow cytometry for multiple myeloma became negative and continues negative now 4 months after treatment. Sorry, that was 3 months after treatment, 14 weeks to be exact. You can see his IgA curve up there, which is incredibly impressive with the very high IgA to begin with, and then at day 0, the CAR T cells were given, the IgA precipitously dropped down to undetectable levels at the current time. This is his bone marrow slide at multiple time points, and you can see the H&E staining showing the bone marrow cellularity before treatment, hypercellular, CD138 staining showing just greater than 90% of his bone marrow being taken over by bone marrow. The pink are the multiple myeloma cells, which are CD138 positive, and then BCMA, which was fairly dim in this patient's myeloma. In contrast, 4 weeks after treatment, his bone marrow was hypocellular. CD138 positive plasma cells were completely absent. I think that's the most important finding of the study, that we could completely eradicate the malignant plasma cells in these myeloma patients. In contrast to before treatment, the pink CD138 cells are completely absent. Again, 8 weeks after treatment, same findings. The bone marrow is recovering, cellularity is coming back, but the CD138 multiple myeloma plasma cells are still completely absent and continue to be absent at 14 weeks after treatment as of this week. This is the first example of a CAR T-cell or any other type of T-cell therapy completely eradicating or decreasing measurable multiple myeloma. So in summary, for the first time, we've shown that CAR T-cells targeting BCMA can eliminate multiple myeloma in humans. We've demonstrated for the first time that CAR T-cells can eradicate large burdens of multiple myeloma. Responses included an ongoing stringent complete remission in a patient with a high burden of chemotherapy-resistant myeloma. Of note, this patient was just seen this week. He's still in stringent complete remission. 3 months after an autologous stem cell transplant, he had 90% bone marrow plasma cells. So this treatment can work in at least one patient who had very chemo-refractory myeloma. I want to note these responses are obviously very, very early and require much more follow-up. Toxicity was also substantial but reversible. And similar to that seen on other CAR T-cell trials, amazingly, the toxicity was very similar to what we've seen in treating ALL patients, acute lymphoblastic lymphoma patients with CAR T-cells in the past when we were doing CD19. The toxicity was very similar. Anti-BCMA CAR T-cells are a very promising new therapy, but as I mentioned, very early and very, very early results that require much more follow-up. Thanks.